Is a friend of mine, Dr. Eric McLaughlin. He is a professor of medicine in Africa Hope University in Bujumbura, Burundi, in East Africa, as well as an adjunct clinical instructor in family medicine in the University of Michigan. He did his medical education and residency training in Michigan, studied the Summer Institute of Tropical Medicine in Johns Hopkins. He's been serving in East Africa since 2009 and has a real adept perspective on one of the core values for the Center for Global and Community Health, which is contextualization. And he's going to talk to us today about what are some of the adaptations that you need to do in order to function well in global context. So I hope you'll help me welcome Dr. McLaughlin. Thank you.
Good morning, everyone. Do I have this positioned correctly enough that if I'm looking forward, you can hear all right? Great. And in the booth, we look all right? Good. All right, well, thanks for the opportunity to talk with you guys. Thanks, Mike, for the invitation and for the introduction. We will have just a couple slides of finding out who is talking to you so that you can contextualize the rest of the talk. So it appears that the first thing I should say is that I am a person that has no financial conflicts of interest, so that's the first piece of who I am, apparently. I am a family medicine doctor. As Mike said, I trained at the University of Michigan, and since 2013, I'm working at a hospital in the rural interior Burundi called Kibuye Hope Hospital. And that hospital is the primary teaching facility for an urban-based medical school called Hope Africa University. And so I am serving as one of the core faculty members for that hospital. That's my wife, Rachel. She's an OBGYN who works with me, and our 3 kids. Story for me is there's a couple of unique parts to this, so I'll share them with you again so you kind of have a picture of who I am and what my experience has been. I finished residency training in 2009, so just a bit over 9 years ago, and there was an interesting moment about 18 months before we finished training where Rachel and myself, who were both interested in doing international medicine in Africa when we were done on a long-term basis, had a conversation with 2 other families that were friends of ours that were both medical. In one family, the guy was an ophthalmologist, and the other one, the guy's a general surgeon. And they were interested in similar things, and we had this kind of powwow about 18 months before of saying, our family stories seem to have kind of converged. They bear a lot of similarity. They could be very complementary. Do we think that there is a common purpose that could await us, or do we think this is just coincidence and it's nice to meet you and have someone with common interest, but we're going to now go our separate ways? And so, long story short, we ended up deciding to pursue the work that we've done and everything since then until right now, as a community of families together rather than as individual families. So that team, which went through all these following steps together, formed in 2007. And then together, when we finished, we all moved to Kenya, the same hospital where Mike lived for 2 years. We lived there before Mike was there for 2 years with the same program. And then during that time, we were learning from some more experienced people, and we worked with a lot of different educational models, which was great, and we used that vantage point on the ground there in East Africa to basically scope out the rest of the continent and to try to find opportunities for a long-term investment somewhere else. And we decided to go to Burundi, and so in 2011 we returned back, and we engaged with our current kind of parent organization on the state side, which is called Surge. They're based out of Philadelphia, to go to Burundi. We did some preparation things. That's when I went into tropical medicine school. And then in 2012, we all moved together to France. And we lived in France for a year and went to French language school so that we could do all of our subsequent work in Burundi in French. And then after a year of that, in 2013, we moved to Burundi in a little village called Kibuye. So that's where we are now. And that team of 6 adults and 2 kids in 2007 is now about 50 North Americans who live together. It's continued to kind of grow and grow and grow that now live together in the middle of nowhere in Burundi. So if you don't know where Burundi is, even though you're at a global health meeting, that's okay. Because there's very few people outside of global health meetings that know where Burundi is, and even within it. So Burundi is in East Africa. You can see it on the map there. Its sister country, which is of similar size and shared cultural history and language, is Rwanda to the north. And then to the east is Tanzania, going all the way to the ocean. And to the west, wait, did I get that wrong? Yeah, no, to the east is Tanzania, and to the west is DR Congo, going all the way to the Atlantic. They were, after World War I, they became a Belgian protectorate, and that's the reason that French is their primary language of education, and the language that we function in. It is a really lovely place in a lot of ways. So most of the country is equatorial highlands. So if you get outside of the capital city and you start driving to where we live, you spend the first hour on an extremely nauseating steep drive. It's kind of like going up to Signal Mountain for 3 times as long. And you get to the top and you've climbed about 5,000 feet. And the rest of the country is rolling hills at high altitude and about 75 degrees every day, year round. So if you want to come and visit, you can know what the weather is before you pack. Beautiful people, beautiful culture. They have these really awesome traditional drumming things where these guys hollow out drums out of tree trunks. They weigh about 100 pounds. They put them up on their head, and they play them as they're dancing around with this 100-pound tree trunk on top of their head, and it's really incredible. Lots of things to love about Burundi. They have a long and very tragic history of instability since independence in 1963. They've spent probably about as many years in war as out of it. The last war ending officially in 2005. Multiple episodes of genocide. Again, the last one ending in 2005. It's a Hutu-Tutsi country like Rwanda, and it's a very poor country with a lot of need. If you Google Burundi, which maybe someone is doing right now, you'll find lots of stuff about political instability. Where we live is generally very stable, but very poor countries are usually very, it's hard to be really stable when you're really poor, and that's kind of where Burundi lives on a general basis. If you Google Burundi tourism, which, and you do like a Google image search, one of the primary images is a Burundian guy with like an over-the-shoulder camcorder up to his thighs in water, running away with a terror-stricken look on his face as a giant crocodile is behind him with these jaws open, which I think is about the worst tourism ad ever if you're trying to get people to come to your country. But so why did we go to Burundi? A lot of it has to do with the intersection of two things, and one is need. We, especially with the kind of the innate strength of the team that we had, we wanted to go to a place that was significant need, and very few other places, very few other people from outside were kind of coming into work. So depending on the stats that you look at, there's sort of this dubious distinction battle that goes on every year for who is officially the world's poorest country, and they jockey around for like lowest place. Not that anyone would want that to be the case, but Burundi is one of the countries that occupies that place kind of repetitively along with a few others. The Global Hunger Index, the last year they had data for Burundi, ranked Burundi as the world's hungriest country. They have been the world's unhappiest country recently. They have also been the world's greatest brain drain in Africa. There's been a number of very needy statements about this country. And then we had the opportunity to go there and be integrally involved with education, medical education of Burundians. And this was a really unique find. Normally places that have this much instability and this much lack of development do not have a medical school that is ready to sort of jump in and train these guys. And we found that in this location, and they were inviting us to come and kind of be a part of this. And so the opportunity to work in education in such a needy context is the long story short of why we're in Burundi and not somewhere else. All right, I have a little video, and I have a little audio cable that's going to buzz a little bit, but not too bad. That I'm going to show you guys. It's just 90 seconds to give you some visual images of where I am and what our team does.
In the mountainous rural farmlands of the poorest, hungriest nation on earth, there stands a hospital, founded before the first genocide, before independence, before the last World War, on a single premise: hope.
We're not the best people for this job.
Our students are.
They hear, speak, sense, and feel what we cannot and will not.
Kabuya isn't huge right now, and it's quite remote.
Not much besides thousands and thousands of needy people.
But in an unprecedented move, Hope Africa University, a premier Christian African university, named this place as their primary teaching site for their medical and nursing schools.
So we're planning, designing, and building the facilities that will teach and heal Africans for generations to come.
The students come from everywhere, and for many of them raised in the cities, this place is quite a shock. It's unexpected, but we want to help them grapple with the needs of their own country.
It's about caring and teaching at the same time.
It's about doing it and modeling it.
Facing African realities, even as they're gaining the tools needed to deal with those realities.
Nothing is more sustainable than education.
Knowledge and ideas, faith, hope, love. These are the only resources that grow the more we share them.
It's more than just bringing specialists from around the world here to teach and heal in rural Burundi.
We are only interested in this work so far as we can raise up a generation of societal leaders and community servants.
From Africa, for Africa.
All right, so to kind of sum this up, the main branches of what we do are clinical care, medical education, and hospital development. So we've been involved in a lot of like building projects and QI projects and trying to make the hospital function more and more like an African university hospital. All right, I'm going to move on from that. That's enough introduction about who I am to talk about our main theme today. So I have entitled this Relearning Medicine, 3 Adaptations for Global Health. New material, I haven't presented on this before, so I'll be interested to get you guys' feedback on how it goes. Before we get started, I do want to throw one caveat in here about using the term global health in this context. Global health is very big, and what I'm talking about specifically has to do with Western-trained medical professionals or physicians entering into an international context. And by international, like, it doesn't mean I'm going to Italy. What we normally mean, and just to be clear about it, is going to under-resourced and often tropical contexts. So we're talking about Western-trained physicians adapting as they move into that. And that is a very small part of what goes on. I think most of what is being done in global health is being done by people living in those countries who are from those countries. They're working, they're doing fantastic work. We ought to support them. I think there's also a role for people like myself who come in from the outside. I think that's the audience largely that I'm talking to, so that's what we're going to focus on today. But I do want to sort of say I don't feel like that is what global health is. Before we go on. It's one part of it. So let's start with this. This is an article that was published 2016 in the Malawian Medical Journal. That is a qualitative study of Malawian impressions of expatriate physicians. So there's actually had been a good bit of data about how Westerners come to a place like Malawi and the benefits that it has from their perspective, but very little about how the Malawians were perceiving this exercise, and so that's the aim of this study here. Great study. It's worth reading if you get a chance. And there were benefits and there were challenges that Malawians identified with working with expatriate physicians that came to their location in Malawi. And so I've skipped the benefits. They are there, and they were good. You can read them. But I want to read from the part about challenges. So several themes emerged regarding challenges with expatriates, including, there's 4 things here: lack of understanding of culture-specific issues, poor adaptation to low-resource settings, communication issues with patients, and self-serving and exploitative intentions in some of them. So the 4th one, exploitative intentions, that's a moral question, and we're going to set that aside for right now. But I think it's fair to say that the other 3, understanding of culture-specific issues, adaptation to low-resource settings, and communication issues with patients, can generally be summed up by the idea of adaptation, or contextualization, if you like. So that brings us to kind of the primary thesis question which I want to put to you guys today. How must Western-trained physicians adapt to be effective in global health? What do people like us need to do? And I will say, I don't know if anyone here is in this context or not, but Africans or someone from another part of the world who come to the West and are trained and then go back also have some adaptation kind of things they have to work through too, because of, they're different, but they're present as well. So I'm going to put this question to you guys, and I'll repeat any answers for the sake of the people who are listening. But what do you guys think? How must Western-trained physicians adapt to be effective? Learn the culture. What do they need to learn about the culture? That's a very good answer. What do they need to learn?
When it comes to the language, sometimes words or different types of words may mean different things depending on where you are.
Right. And that's it. So different types of words may mean different types of things based on where you are, which is a wonderfully nuanced answer to kind of show just how quickly the waters get really deep. Because even if you know the words, which can take a lot of effort, the words may mean different things, not just here, but it may mean a different thing in the same place in a different context, or talking to a different person, for example. Okay, other things that we need to do to adapt and be effective? What about, okay, resources, what about them? Mm-hmm.
So relying more on physical exam findings versus lab findings and imaging, kind of learning how to go back to the basics.
Okay, so learning how to go back to the basics and use things that we often don't use or don't count on as much in the West because we have technology that's available to us. Okay, so you can correct me if I'm wrong. We could sum up maybe what you're saying by one of the resource questions is learning how to do without certain resources that we have here and still function, and not just say, I don't have a CT scanner, and so I'm just going to lay down and quit. You know, how do we continue to go on without that? Okay, other ideas?
You have to be aware of the medical issues that happen where you're working.
Okay, you have to be aware of the medical issues in that context, which may be different than your own. Would you want to give an example of that?
So like when you hear different symptoms, you might think about something based on your training or where you are, but there's local diseases that you don't really focus on.
Right.
That might be the cause of it.
Okay, so instead of learning to do without in the resource question, you're talking about learning how to grapple with something that you actually didn't have, and now you have, and you don't necessarily know how to deal with it. Yeah. So that would be the flip side of saying, like in Burundi, where there are 3 CT scanners in the country, and usually there's one that works. You don't finish medical school with a really good ability to interpret CT images, you can imagine. So if they were to come and start studying or functioning in a Western context, they would have to be like, all right, CTs, I got to learn how to read them. Whereas we might show up in Burundi and say, malaria, never treated that before. Got to learn how to do it because I haven't done it before. So adding to your knowledge base to deal with the issues that are there. Okay, good answers. Other things? Could you say roles of care?
Roles of care based on culture.
Based on culture.
What they want to get out of medicine or what's not important to them based on spiritual.
Okay, yeah, so could I say maybe understanding what the patient is actually looking to you to get, why they're seeking care, what it is that they're wanting, and how they expect it to kind of go forward. Yeah. All right. Anyone else want to throw anything out, or should we move on to me actually talking about it? All right. So this is, in my mind. Thank you for the feedback there. You guys said some things that I expected, and some that were in addition to that. When I was thinking about this, I think that normally the answer to this falls into 2 parts, which can be summed up by saying, if I've been well trained in the U.S., I need to adapt in 2 primary ways. One is to accept to not do things that are impossible in that context. Okay, we talked about that. And 2 is to learn about some problems that aren't familiar to me, and we talked about that too. Such as malaria, maybe weird things like vitamin deficiencies. And then if you're really astute, maybe you thought, I don't know how to treat severe acute malnutrition. I thought before I went to Kenya you just gave them food, but it turns out it's a lot more complicated than that. So it would be the kind of the rare person that actually had the foresight to think of things that are sort of half nuanced like that you do have to learn how to do. And I would say that normal answer is a great starting place, or it's at least a decent starting place. I do not want to discourage anyone from jumping in and getting their feet wet. I think they can be helpful and effective with a humble approach to what's going on around them if they have those 2 things in place. However, I think if we want to maximize effectiveness, we want to look beyond that and try to embrace a broader range of adaptations. So today we're going to talk about 3 of them. We're going to talk about technological adaptations, economic adaptations, and educational adaptations. we're going to talk about them because they're ones in which we have grappled with these things and come away with some examples of them that may be of interest to you or may be useful illustrations. All right, so technological adaptations. 2014 at my hospital in Burundi, we have a newborn who's born at 29 weeks who weighs 1.3 kilograms. Quite premature for this context, enough to really create some problems because we don't have a NICU. What we have is cardboard boxes and blankets. And this is the normal practice when we showed up is there's a small baby, you put him in the cardboard box with the blankets and you pile a bunch of blankets on him and you hope that you keep him warm. And that was, obviously there's a lot of different complications that could come about because of prematurity, but this was the solution for the hypothermia problem. And again, it's not hot where I live, so the hypothermia problem at night is very real, and people are quite scared of it. So the question is, now I'm here as a Western inside-out kind of person, or outside-in kind of person. What do I want to do? Not just for this baby. I mean, I don't know if there's a lot I can do for this baby. Like, that's all we got is a box. But what do I want to do for this kid, and what do we want to try to do development-wise for all the other kids that are similar to this in the future? So any ideas? What are your thoughts? What could we try to do? And they don't even have to be a right answer. You can just throw them out. Like, what are our options? And we're looking long-term. You can go look for new materials to bring into this situation. You can try to develop it. You can try to educate nurses. What do you want to do?
Can you place the box in a room that has constantly running heat source, like a kitchen or an oven?
Yeah, that's an interesting idea. Find a room that's hot and kind of try to use some of that heat for a positive benefit. I like that. All of our cooking is outside. So we can't do that, but that's a really good idea. It's similar to how we initially did phototherapy too, which was it's too cold to just like expose the baby outside, but you can take them, and so the answer was like, I write this order, like put them near the window, phototherapy. Other ideas?
Speak to the parents, just let them know what the risks are, the prognosis are.
Okay. So we can definitely do that, and we should do that. Speak to the parents and let them know what the risks and prognosis are.
Like kangaroo care, like have skin to skin?
Yeah, okay, so kangaroo care, skin to skin, which is quite popular and great. And is actually, in my experience, a lot harder to get, and not impossible to get moms to do well. But the number of times that we've like talked about it, and then you come in, the baby's got like 3 blankets around them, and you're like, that's not skin to skin. So it takes some work, but it's free other than personnel time and resource, and can be very effective.
Is find a way to elicit funding. And this is 2018. And
Yeah.
You have social media, and people see this most likely you can get some funding and find a way to find cheap incubators.
Yeah, okay, so here's another option here is, we can raise some money on this. Like I could show a room of people, like right now, a picture of a baby in a cardboard box, and someone's going to be like, look, I want to help this situation. And with that, you're suggesting what we could do with the money would be to find some cost-efficient incubators to bring in. Okay? All right, let's leave the discussion there for right now. The two things that I was sort of anticipating is, one, the issue of kangaroo care, as was discussed. Here's a picture of a mom at our hospital doing kangaroo care, or maybe a grandma, I'm not sure. And then on the other side, the idea of bringing in incubators. If you go to a lot of African hospitals, and I would imagine this is the case in low-resource hospitals in other parts of the world, one of the features that you will almost inevitably find if they have neonatal care is a room of broken incubators. Because they come in, even if they were all right, but some of them were kind of old or used, and it's not that they broke down, well, they may break down faster. For example, we've had very unstable electricity, and we fried all our electronics for a couple of years before we figured out how to fix that solution. And there's the room of the broken incubators, and there's usually, my guess would be there's more broken ones than there are functioning ones. And yet incubators, as was suggested, remain a very viable standard for treating hypothermia in neonates. It's an important piece. Kangaroo care is great. For preemies, I don't think there's anyone out there saying incubators need to be done, and we just need to replace it all with kangaroo care. There still seems to be, we live in the world of saying this really is the standard, and for good reasons. And so we have this need for incubators, and we have the problem of imported technology, especially when you don't have any systems in place. If an incubator breaks here at Erlanger, what do? I'm guessing it's either you call the in-house guy who fixes them, or you call the out-of-house guy who fixes them, one of those two. But when you don't have an in-house or out-of-house guy who can fix your incubators, or you don't have the parts that you need to fix them, then it can become a very difficult situation. And I can give the example of one of the things that we tried. In 2014, around the same time as the case example I gave you, we purchased a digital X-ray scanner because we had this super old X-ray machine, just plain film X-ray. And we thought these will be better films, and two, they will be cheaper for the hospital, so the hospital would have more kind of money to pay salaries and things, because when you shoot a digital X-ray after you've paid for the money for the machine, there's really no operating costs as compared to the cost of the film and the reagents to process it and such. It worked really, really great for about 7 months. And then one part of that machine broke. It was the part that took the digital film and scanned it, the scanner, to get it into the computer. And we have not been able to fix it since then. And we have actually spent probably thousands of dollars trying to get it fixed and shipping it back to the US and all these kind of things. And I don't know where that project is at now. Maybe it'll get fixed any day. But we've been back to our plain film X-rays since then. And that was very valuable for us to learn what we sort of already knew, but thought it wouldn't have applied in this case, that when we brought this technology in from outside and there's no one in the region that really is set up to fix it, that you get into a difficult situation pretty quickly. All right, so what have we done for the incubators? We have built incubators. And this has been kind of like one type of adaptation that we have done. What we did here was we actually took a model of an incubator design that's similar that we had seen at the hospital where Mike and I both lived, and we changed some things about it and started manufacturing them there in Burundi. They are built with local materials, all local materials that can be replaced when they break, because they still do break. We have I'll show you a picture of this, but they're heated with light bulbs underneath the place where the baby stays, and we have hooked them up to a thermostat so that the number of light bulbs goes on and off based on temperature control. We have changed them somewhat so that, I'll show you another picture, but they're kind of inside the mosquito net with mom, and there's doors on both sides so that the nurse can go by the front and examine the baby or give medicines, and the mom, when she's in the net at night, can open it up from the back and feed the baby without having to take the baby out into another room or something like that. We're working on phototherapy. We have these like auto stick kind of billy lights that attach to the top of it. They don't seem to be as effective as we'd like them to be, so we're still working on that question. And when we have shown this to other Burundian hospitals, they have been very excited about it and have started ordering some of our units to be manufactured to go to other hospitals. So here's a couple pictures of them. You can kind of see in this, I can't get my mouse up there the way I wanted to. You can see in this picture on the left how the bed is sort of in the rack with mom, and mom can open it from the other side and the nurses can open it from the front. And then you can see in the picture on the right the light bulbs that are underneath. And they've definitely given us the ability to address the hypothermia question in sometimes very, very small babies using materials that we can find in Burundi. So technological adaptations abound. There are a number of people doing really cool work with this. A couple of the other ones that we have used. There's a company out of Massachusetts called Little Sparrows Technology that makes this thing called the Billy Hut, which is, and there's really good data on their work, really potent phototherapy that comes in this, that thing's like just big enough for a baby inside of it. It folds down into something that looks like a camp chair. It costs way less than traditional phototherapy. And we've had a couple of their units that we've been using in Burundi. And then these things, the arc light is super cool, and I have one, and I actually brought it to America, but I forgot to bring it with me to Chattanooga. I was going to like pass it around. These are solar oto-ophthalmoscopes. They're about the size of a tongue depressor. And the end here, this is the ophthalmoscope part. And then this part is the otoscope part. It comes with a couple specula that you can just kind of attach onto it. And I keep this in my pocket all the time, so it's always with me. So if I'm on rounds, I don't have to say, why doesn't someone go find a otoscope, because we don't have them in with the patient beds. And they cost, anyone want to guess what they cost? They cost about $10. So they're made out of the UK, and we bought them for £7 a piece. So we bought like 30 to get. So super low cost compared to traditional otoscope ophthalmoscopes, quite effective, really well adapted to the setting that they're in. I mean, you can solar charge them or you can USB charge them. And they're with our doctors all the time. And so you can look around and find a lot of fun technological adaptations for the settings, the various settings that people work in. All right, moving on. Any comments on technological adaptations before we move on to economic? All right, we have a multiple choice question for you, because that's American. A 53-year-old Burundian farmer referred from a nurse-run health center with a blood pressure consistently 157/98-ish. What should we do? A, lifestyle changes and send him back to the health center and just the nurse can tell you if it gets higher than that. In other words, no medical treatment for that. B, do the lifestyle changes but also start him on either a thiazide or a calcium channel blocker and then have him come back in a month. C, start him on those meds and check a basic metabolic panel if you can, some electrolytes and a creatinine. Or D, do all those things but also check an EKG and lipids if you can to look for other associated cardiovascular problems. All right, show of hands. Who would like to do A? Who would like to do B? Who would like to do C? Who would like to do D? All right, and so that means we got about a 40% voter turnout, which isn't too bad for local elections, I believe. And the main question, especially when I'm asking the question in this context, is, all right, we know he's talking about adapting. I got to think about adapting. Do I want to do A or B, is what you guys are talking about. So in other words, the question is, do I give medicines to this man? Is he hypertensive? Yes. Is this hypertension a cardiovascular risk factor if untreated? Yes, it is. So why are we even having this discussion if we know that those two things are true? What is that? Because the resources are limited, all right? Yes. So we are wondering about the potency of this intervention in this context, right? Is it a problem? Yes. Is it a big enough problem that we want to ask this man to pay for treatment? That's the question. And so because of that, we're vacillating between A and B. But apparently, based on the fact that no one voted for C and D, we have thought, but we can get by without checking. I mean, you know, if you put someone on a thiazide diuretic in the States, are you going to check their electrolytes from time to time? You're going to make sure they're not hyponatremic or whatever? Yeah, probably. But we're kind of thinking those things I can probably do without it. But treatment, we're not sure if we can do without that or not. Right. So that's good. We've already kind of done some contextualization. You're not automatically choosing the thing that you would do here, but we're wrestling with how much is the appropriate amount of contextualization. So this is a question of relative power of interventions in a resource-limited setting. And there are a number of ways to measure this. In the West, I think the most common one that we talk about is number needed to treat. You can look at it in a number of ways, but number needed to treat kind of speaks to the potency of a given intervention. A small number needed to treat is like a really great thing, and a large one is not. International health, global health literature often talks about DALYs, disability-adjusted life years. So, and then dollars to DALYs. So it's like the number of dollars you have to spend to save one disability-adjusted life year. So again, low DALYs is potent compared to high DALYs. Does anyone want to, and we'll even leave this with the less aggressive old terminology for hypertension of calling this stage 1 hypertension. I do realize, even though I was in Burundi, that this has changed, but let's refer to 160 to 140 to 160 over 90 to 100 as kind of old school stage 1, old school meaning like last year, stage 1 hypertension. Number needed to treat for that. How many people do you need to treat with that before one of them has a saved clinical outcome? The answer is 700. So 1 out of 700 of those patients will benefit, and 699 of them will be being treated because we don't know who the 700th one is. Now, when you get above 160 over 100, it's a really dramatically different story. The number you need to treat drops 20-fold, and the number you need to treat is 35. Okay? Both of them are hypertensive. Both of them have real benefit, but the power of the benefit is very different. I hope that you can see the importance of this information for the applicability of the case that we're talking about. When I share this, so the upshot of this is I can say, and I would probably say personally, that in a really low resource setting, treating of low risk asymptomatic stage 1, old school stage 1 hypertension is potentially a bad idea. And I have given this presentation to Burundians, and the Burundians express a sentiment that at least some of you have right now inside of you, which is that feels like giving crappy stuff to poor people because they're poor. Like, you just have a small risk and you're poor. But if you were rich, I would take care of your small risk, but I won't take care of your small risk because you're poor. And that feels like unfair and paternalistic. And they feel the same way. And then I ask them, well, first I point out, it's not you, Burundian medical student, who are going to pay for this. It's them. So if you could say to them, and they could understand, which unfortunately they can't, in my opinion, the people I deal with, I would like you to participate in a community-based experiment where I will treat 700 of you. You will all pay. It's not that much, but for you it's a lot. And at the end of the year, 1 out of you 700 will have a difference in your life that's quite important, and 699 of you will have no difference whatsoever. Would you like to pay to enter into this situation? My African colleagues have said, no, they would not want to do that, by and large. So this can feel kind of paternalistic, and it's very difficult to enter into shared decision-making. We do all sorts of stuff like this in the US. Like, I'm going to have shared decision-making and now talk to you about something that you don't understand, and we're going to call it shared decision-making. And what happens with that? At the end, the patient says to you, well, doctor, what would you do? And you try to give your best answer, and that's kind of how it goes down, in my experience. There's a number of ways in which it can go down, but that's a very common outcome. So there are some ethical kind of considerations about this that are worth talking about, but in my impression in talking to a bunch of Africans about this is when the information is presented in this way, they don't think most people that are subsistence farmers living in the rural interior of their area think this is a good idea. There's lots of examples about this, so just think about them. Do I want to check electrolytes for patients that are on an ACE inhibitor chronically in a similar economic context? If someone is on warfarin, we don't have patients on warfarin, but when I was in Kenya, we had patients on warfarin. What is the appropriate return visit interval that you would want to give them? Transport cost is a huge burden of cost for people getting care in poor countries. Paying money to come back to the hospital is oftentimes more expensive than the hospital visit by a good margin. So can I put you on warfarin and be like, I'll see you next month? 2 months? 2 weeks? I would like to see your INR in about 3 days, but I can't do that. So what is the appropriate return visit interval? Should all newborns get universal tetracycline, eye ointment, and vitamin K? Should everyone be on DVT prophylaxis if they meet the same criteria that we use for thresholds for that in the States for hospitalized patients? Okay, I have my own opinions about these things. They're not terribly well informed because it's a little bit hard to make these decisions. I would say some of these yes and some of these no in my context. How do you decide? And it comes down to trying to use some of the tools that are out there for this. So thankfully, we're not utterly alone on these questions. I'll show you a couple of them. This is relatively small, but hopefully you can at least see the idea. This was in Guinea, in West Africa, and they're ranking interventions based on how many dollars it took to earn a dali for these people. So you can see that treating pneumonia in children costs about $3 to save a year of life. Going all the way down, you got all sorts of stuff on here, including like pit latrines and safe water. And then treating hypertension is down here at $2,281 to save a year of life for someone. So it gets at this, how do I know the relative effectiveness of this? And based on this, there's an acronym for this that I don't remember, but you can do these ratios between two interventions. And the World Health Organization provides a lot of these resources to try to help people to figure out on the policy level which interventions are worth going for. And a lot of it is this one's better than this one, this other one. This was from Vietnam, and it has the stuff that we're talking about in our case example, systolic blood pressure greater than 140 or greater than 160. So the far upper right with the little hyphens is the more expensive intervention of treating old school stage 1 hypertension. And then stage 2, all of a sudden you see how this drops down to be much less costly in order to bring what matters to the patient in terms of a health intervention to bear. And that's really good, but doesn't fully answer the question, because those tools can help you, can give you comparative answers. This intervention is better than that intervention. But the question in front of a certain patient is this intervention good enough? And that's a different question. People have tried to answer this question too, and there is a whole world of debate about what good enough is. I'll give you one example. WHO has, as far as I know, they are still advocating for this threshold of GDP as a way of deciding it. So they say if the dollars to DALI for a given intervention is less than 3 times the GDP per capita of a given country, then that's a good intervention. If it is less than 1 time the GDP per capita of a given country, that is an excellent intervention. And they use these things to try to decide what should be put in place. All right, here's my practical take-home point right here. If you are in doubt, start by relying on local practice and national guidelines. That is not intuitive for people when they come from a Western-trained area known for excellence, for good reasons, and then show up in another place. I'll give you an example. A number of African national guidelines for hypertension define hypertension as hypertension is greater than 160 over 95 or over 100 sometimes. MSF does the same thing actually in their guidebook. Why do they do that? Probably based on the conversation we just had, if I communicated effectively, you have some idea of why they do that. They're just like, you know what? We're just going to call hypertension stage 2 hypertension because that's what we're interested in treating. In stage 1, we're not even going to talk about it because it just confuses matters. I can show up and someone says to me, yeah, hypertension is a blood pressure greater than 160 over 95. And I will think, they are misinformed. They are wrong. Their national guideline is misinformed. They don't know what hypertension is. When in fact, the answer that they've designed has really good reasons for its contextualization. So, is current practice on the ground, wherever one might land, good? Not necessarily. But I encourage you to start from the standpoint of this probably exists for a good reason, or let's say it exists for a good reason until proven otherwise, and try to give them the benefit of the doubt that for this context, the practice that's in place may have some good reasons. And so instead of coming in and saying, I know what hypertension is and you don't, let's change it, of saying, this is the practice, I don't necessarily understand it, but let's try to find out why it's that way before we go about trying to change it. Caveat for that, but when I do that, it can feel like malpractice, or it can feel like devaluing life or something else like that. We hold our standards of care, which are sometimes quite arbitrary, but sometimes exist for good reasons, very close to our heart. If you are used to doing something and you can't do it in a given context, this is the point about resource limitation that was brought up earlier, it can be really hard to not do that. You feel like you're treating the patient poorly. But that is not necessarily true. And I would like to give you a challenge to that, to hold also the idea that doing what seems normal and standard of care to me may not be the best thing for the patient that's there. That's hard to live with that ambiguity, but we don't want to automatically say, I feel this way, therefore it's done. All right, I'm taking more time than I meant to, so we'll go pretty quickly through the last one here. All right, educational. I work and do a lot in education, and education is an increasingly large focus of global health, which is fantastic, and I love it, and I want it to be that way more and more. It brings up all sorts of other issues. One of them, I'm a family medicine doctor. One of the questions, for example, is what is a family medicine doctor in Africa? Africa still has, probably the majority of doctors are what are called general practitioners or some form of that, so people that did not do a residency at all. There are an increasingly large number of family medicine residency training programs in African countries. There's probably about a dozen now, a dozen countries that have programs. What are they? How are they different from the other thing that's there? We don't have this question in the US anymore because GPs are basically gone. But in a context where they coexist, how do you decide that? There's a whole consensus statement about this. This is from 2009. And the term they landed on is a primary care consultant, which is like an oxymoron in the West. But they talk about what that means. The point that I want to make is training family medicine doctors, and a family medicine doctor in Africa looks different and is trained different than a family medicine doctor in the West. Very different, in fact. So I can come in as a family medicine doctor trained in the West and add things to that, but I certainly cannot do it alone, and I'm not making clones of myself. That's not what they're looking for. The example that I want to talk about that we work to develop is this question of bioethics clinical cases. So someone about 5 years ago said, hey, can you teach a bioethics module to the students? And we said, okay, and we worked on developing a curriculum for it. And we wanted to develop cases for the students to discuss that were appropriately contextualized to our context. And the question, and I'd love to hear your thoughts on this, but for the sake of time, we'll kind of skip through it. What factors affect the relevancy of a case? Because if they're not relevant, they're not useful. And there are three big ones that have stood out to us in doing this for 5 years. One is cultural context. So I'll read this case, which is a cultural context kind of case. A mother of 8 children is hospitalized for a cesarean for baby number 9, while baby number 8 is hospitalized for severe acute malnutrition because of inadequate food supply at home. The mom agrees to a tubal ligation, but the father refuses, not for religious reasons, but because he says a large family is the truest blessing. It's a traditional African family value in a lot of ways. The mother asks you secretly to do the tubal anyway and not tell the father. What do you do? Real case, happened in Kenya when we were there in Kenya. There's a number of different cultural values and contexts that are important to recognize there, and I probably don't even see all of them. But one big one is that the wife does not get the final say. For better or for worse, that's the way it is right now. They won't do a tubal ligation normally without the husband's signature. The moms don't think that's that weird, or if they do, they don't express it, because that's kind of the normal way that they're used to things kind of functioning. What do we do when we're faced with a situation like that? Students have loved talking about this case. They see it, they understand it, they see the issues. It is a great cultural window. I love precepting these discussions because I learn so much about them every time. The second thing that affects the relevancy of our clinical cases in bioethics discussion is severe resource limitation. So this one, we have a lady who presents in a coma. She needs oxygen, like nasal cannula oxygen. She has a head CT. She's in the city. Shows massive hemorrhage. Recovery is impossible. You can't take her off oxygen without her becoming basically immediately dying. The hospital has one other concentrator, which is shared by 2 children with severe bronchiolitis, and there's no other source of oxygen in the hospital. So do you continue oxygen therapy for the comatose woman? What do you do if another kid shows up who needs it? This is, and I'll say, with the question of resource limitation, the students identify with this question. We tried it initially with someone on a vent. Totally didn't understand. They don't have vents. The question devolved into all sorts of useless comments because they couldn't understand the resource limitations that we were talking about in that case. But in this case with oxygen therapy, they can understand this one, and it's generated a lot of good discussions. And lastly, we have the question of insufficient professional expertise, which also creates a number of different ethical scenarios for us. This one, you're the only doctor at a rural hospital with a pregnant lady who's hemorrhaging. needs a C-section. She could die easily if you try to refer her to the nearest place that can do a section, but you really don't know how to do a section. Not really. You know the theory of it, you've watched a lot, but you haven't actually started doing sections on your own. Do you try to save her life, or do you risk her losing her life by sending her somewhere else? So we're trying to pit beneficence and non-maleficence together in the context of insufficient professional expertise. They encounter this all the time, and it's a big issue. And so the creation of these contextualized bioethics cases is another way in which we've tried to adapt. This says 9 o'clock, so I'll just conclude by saying we can start with a clinical knowledge question as what we need for adaptation, but that's not our finish line. If you are faced with something different, start with the assumption of legitimacy of local practice for their context. And then the rest of it is just endless exploration into the different ways that we will never cease needing to adapt. Thank you very much.
Do you have any burning group level questions for Dr. McLaughlin?
What are the answers to those questions?
Yeah. Yeah. I am currently, if you have answers to those questions, you can come and tell me what they are. And they will be included in future presentations.
All right. Good morning, I'm James Hayes. I'm a family doc as well. Is the culture amenable to sort of bringing the husband and wife together and discussing that? Or
yes. Yeah, you can bring them together and talk about it.
But they definitely still disagree despite your best efforts or whoever's best efforts.
Yeah, the actual end to that story is one of our really excellent African doctors, who you know, took the husband into another room and kind of told him off and verbally strong-armed him into saying okay, and then he said okay, and verbally strong-armed him, I believe. I wasn't there. And he said okay, and they did the tubal. But for the case of the discussion, the ethics case discussion, we kind of left it hanging.
Right.
And we've gotten, my favorite answer is, I would do the tubal and I would tell the wife I didn't do it, so that she doesn't know and the husband doesn't know, and hey, just sometimes you stop having that babies after a while, and was one of the students said, and you can just see imagine the generation. And I will say, this is a little bit of a side item, but there's a big focus in African education about developing critical thinking skills. I don't know if you guys have encountered this, but there's a general idea, which has some legitimacy to it, that their education system doesn't foster critical thinking skills, but they're capable of it. Ethics cases are a great way to do that. It really gets them thinking and expressing opinions and having to articulate their thoughts, and it's been really fun to do with them.
Well, because of time, which is one of my favorite African phrases, we should break here. I think Dr. McLaughlin and I will be around for some coffee and get some more food on your way out as you go back to your daily work. Thank you guys for coming.
Thanks.